hello everybody, welcome, and a big welcome to Jeff, who's going to be doing a talk for us today. So welcome, Jeff, and thank you.
Thank you, Mike.
Yeah. Okay, so Jeff is one of the moderators on our Facebook group, and he's been a moderator from 2017, and I always appreciate having him there, and he's sage counsel, I guess, when things get quite heated in terms of debates on the group. So thank you, Jeff. And tonight, well, tonight for us, but I think it's afternoon for many of you, we're lucky to have Jeff give a talk to us on some of his work. And it's also nice to have a sort of quite intimate group, and we can sort of really try and engage and think about the ideas that Jeff is going to present to us. Just an introduction for Jeff. So Jeff is a licensed clinical psychologist and board certified medical psychologist in upstate New York. He has worked in inpatient, residential, and community-based settings, in urban and rural settings, and with the criminal justice and forensic specialty programs in New York City and upstate New York. He was primary psychologist for a forensic and behavioral disorders unit with a state hospital in Binghamton. I hope I said that right. Binghamton, New York.
Mm-hmm.
Binghamton, right. New York, and team leader for a specialty sex offenders treatment team. Jeff is currently the director with the Academy of Medical Psychology and a psychologist with a private practice where he specializes in work with patients with problems in mood, trauma history, PTSD, personality disorders, and interpersonal conflicts, and medical health problems secondary to psychological and stress factors. And Jeff is very busy, so I'm so pleased we were able to get some time to have you share your ideas with us. And so thank you, Jeff, and over to you.
Thank you, Mike. Okay. So we now have PowerPoint. Everybody can see my title page.
Yeah.
Okay. Few thank yous first. Thanks for the nice introduction, Mike, and thank you also for the psychoanalysis and psychoanalytic psychotherapy Facebook page and that whole project that it is, with all of the pages and activity and all of the riches that you provide the psychoanalytic and psychotherapeutic community. It's just an extraordinary feat. And the fact that you have put all this together is what makes it possible for myself and the other presenters to present. So I really thank you for this whole project that you've put together. It's really incredible. I think probably many people who participate feel the same way. And thank you also, Yvonne and Michelle, for helping out with me presenting this. And you, I know, are both working very hard as well. And I think also the people who've attended, who are attending, Mike mentioned my busy schedule, but I think these days busy schedule is true for everybody. So I really appreciate people who took some time out of their day and their schedule to attend this. I really appreciate that. So my presentation, Relational Excursions and Amygdalar Pathways, Misattunement versus Attunement with Defenses at Interpersonal-Affective and Physiological Levels. PowerPoint's really amazing thing. It creates customized slides for you based on your content. And I really like this slide. And one reason I'm spending just a few seconds on it is because somebody had posted, I think it was on the PPP page just a couple days ago on Robert Frost's The Road Not Taken. Felt synchronistic to me reading about that and then thinking about my slide that kind of depicts that same idea. I don't know if people read that post or not. I think maybe Claire posted that. Okay. All right. Mike already introduced my background, so I won't reiterate all of that. I'll just say, going to this third point, the patient populations that I've focused on and specialized in over the years, very severely mentally ill patients. I've done a lot of inpatient work and work with patients with trauma, PTSD, a lot of patients with borderline personality, patients with compulsions and addictions, a lot of acting out problems and defenses, a lot of interpersonal conflict, and associated with that, forensic and criminal justice histories. Don't take these as all comorbid. Certainly people have may fall into one of these categories and not have these other problems, but the commonality that I'm calling attention to here is that most of these more severe clinical syndromes or personality disorders, and especially with the more primitive, what we call, sometimes I think our nomenclature is sort of unfortunate, but what we call more primitive defenses are probably associated with earlier life difficulties and traumas, early developmental, infancy into the first couple years of life or so. So given that, the reason I mention that is I think our patient populations and our specialty foci probably have a lot to do with the theoretical and therapeutic models that we adopt. So given I work with patients who have, by and large, probably had traumas and attachment problems very early in life, I work from an object relations perspective, specifically an object relations developmental model, which I'll go into more detail on later. But I think that's worth mentioning, that when we're looking at the sort of foci we work from, the models we work from, it's meaningful to think about that in terms of the populations we work with, because there is a correlation. Okay, let's see what my next slide is. This is just, going back to the title, Relational Excursions and Amygdalar Pathways. I sometimes when I'm putting together something for public presentation, I realize, I should probably go back to the dictionary and make sure I know what that word means. So I wanted to check out excursion. And when I looked it up, I found that there's some really particularly apt definitions. A short journey or trip. When we're addressing attunement with patients, that's something else I'll get into, or misattunement, we can think of these as sort of taking us closer to or further away from the connection with a patient that we're working with. And yet at the same time, definition 3, an instance of the movement of something along a path or through an angle. Even if we go on a bit of an excursion, we are still moving in a particular direction. I don't know how well a military sortie fits with this, but when I get into talking about countertransference and the role that that has in this way of looking at things, I think there's a sort of discipline that goes with awareness of countertransference and phenomena like this, that is part of us being conscious as therapists and in our interactions with our patient. Okay, so I have to my gallery around a little bit here. So why am I doing this talk? What purpose does it serve? So multiple. One, it is emphasizing, I'm emphasizing the role of relational factors in both mental and physical health. The physical health piece, I'm not going to get into as much here, but there is obviously a physical ramification when we're doing relational work, and thus the title, Physiological Pathways, Amygdalar Pathways. I will get into the effects of relational experiences on the physiology of our bodies, specifically at the level of the amygdala. But I will give just a very brief intro also to how that extends further into the body in terms of the stress response and so forth. But some of that's for a later talk. But in general, relational factors, sort of cut across the divide, the sort of really imaginary divide between mind and body. And I'll explain how that is. This highlights the value of psychoanalytic informedness, especially from a relational perspective in health, illness, and healing. I'll talk a little bit more about that and how, recovering psychoanalytic thought, knowledge, and methods for the mental health and healthcare professions is important. Some of you may know what I'm alluding to, and I'll get into it more. The shifts in treatment in previous decades towards approaches like CBT or medications and these kinds of things, which for a while, at least for a long while, pushed psychoanalysis kind of to the sidelines. It's sort of making a comeback, and I'll talk about why that's important from this perspective that I'm presenting. Demonstrates the relevance of relational approaches in context of emerging role of biological change and psychotherapeutic effectiveness. I'll talk a little bit, mention that there's studies that are emerging. They're pointing towards the idea that psychotherapies that do result in biological change are perhaps more effective or more lasting than other types of treatment. For example, CBT, and I'll talk about why relational approaches probably do have more direct effects on physiology. And also talk about the importance of countertransference analysis of countertransference as a psychoanalytic concept and method in particular that is useful towards these ends. One thing, there's going to be some sort of meta commentary as I go through these points and go through the slides, sort of why the structure, why, of the presentation, why the particular slides. So one point I want to mention here is sort of the hammering home idea. This is the way that some of the variables are combined in this presentation are individually and as a whole relatively novel. There's some paradigmatic shifts going on here. So in order to really make certain points, I am at points going to be somewhat repetitive or redundant. So here, just a couple of comments about relational treatments, very in the moment, what's happening now. As I mentioned, I'll contrast relational treatments with some other approaches. Poor CBT, I'm giving it a very hard time today. And as I previously said, psychotherapies that result in biological change are more effective, perhaps more effective than medications. I would say almost certainly more effective than medications, and this can be understood in an integrated mind-body, in terms of integrated mind-body changes and integrations of neuroendocrine events themselves. So I'm repeating myself there, but I want to, as I said, I want to drive home certain points. There's a number of mind-body approaches. One could argue that psychiatry is a mind-body approach. Biopsychiatrist, prescribes a medication which acts directly on the body with the intent of affecting the psyche. I would argue that neuropsychoanalysis, at least some versions of it, there are obviously their mind-body, but not to the same extent as biopsychiatry. But I think neuropsychoanalysis, at least in some versions, is still what I'd call body-centric, or based on a biological substrate. As I say in the bubble there, both mind and body have dependent and independent variable qualities in a body-centric or biological substrate perspective, but the body acts as the anchor in the substrate in which these reciprocal roles occur. Versus this model, which is really a relatiocentric model, when again, both mind and body have dependent and independent variable qualities. Again, they're reciprocal, but that reciprocation is contained more so in the relational environment, or you could say the relational environment is more so the independent variable, or if you're familiar with path models, the determining variable. So in a body-centric or biological substrate model, we think of things kind of as originating in the body. In a relatiocentric model like this, we think of things, including events in the body, as to a large degree originating in the relational environment, or our relationship with the environment. Move my gallery around again. Okay. So I think I mentioned that there is, well, I did mention that there's going to be some sort of meta commentary on the organization of things. And another element of that is a bit of jumping back and forth between domains, talking about relational centric versus biological centric. Now I'm talking about the importance of reclaiming psychoanalytic concepts and methods in our treatment and training programs as we go along. I think people will see, hopefully I arrange this in such a way that it will be seen that the kind of going back and forth is somewhat purposeful, that whenever we're talking about period, or whenever we're faced with or addressing a paradigmatic shift, we have to sort of address multiple parts simultaneously, because things kind of shift together. It's not like within one paradigm you bring in some new information and kind of fit it in the existing paradigm. When we're talking about a paradigmatic shift, then the parts, as they constantly kind of move around. So this going back and forth is somewhat intentional. So with the psychoanalytic methods, as I mentioned before, I think their psychoanalytic concepts and approaches have been, over the decades, kind of pushed to the side with the ascension of CBT, medications, and biopsychiatry, more behavioral and cognitively oriented approaches. And I think by giving more attention to psychoanalytic concepts and methods. We're bringing something back to training programs that is somewhat faded over the years. I worked for quite a few years training clinical psychology students at a nearby university. And like a lot of clinical PhD programs, at least in America, they have gotten very CBT. So over the years, I worked with them, very intelligent and insightful young new psychologists, clinical psychologists in the making, but they often had relatively very little exposure to the relational nuances of treatment, and beyond that, the sort of psychoanalytic ideas and concepts that really bring some of those nuances into view and awareness. So anytime that we're looking at psychoanalytic approaches or informedness with any kind of work we're doing, we're increasing attention to the relational. And when we do that, we're increasing potentially the effectiveness of the treatment. And just one psychoanalytic concept in particular that I stress in this talk is thinking about our countertransference. And I think that's obviously all of the psychoanalytic concepts are interrelated, but I think the idea of countertransference and how, as a therapist, we respond to our patients and their transference, both consciously and unconsciously, plays a very big role in how we respond to our patient, and including how well we attune with our patient. And you're going to see as we go along that attunement plays a very big role in this model I'm presenting. Okay, maybe I could have put this slide in a little bit earlier. It was actually originally a blank slide that I had something else there, but I realized it didn't really fit with the progression. So I prettied up my blank slide, but I did comment on this earlier, this sort of shifting sands of paradigm shifts, that there's a fair amount of back and forth we sort through as we kind of think about, comparing, psychoanalytic and relational approaches to cognitive or cognitive behavioral approaches, or comparing, looking at sort of relational-centric approaches versus, biological-centric approaches, etc. Things are elements of the model are shifting in a correlated way. Okay, so more sort of relative CBT and medication bashing. I say relative because, as I'll get into, there, CBT and medications have a role in patient treatment, but they've been extraordinarily overemphasized, and there's a couple of obvious reasons. There's probably more reasons, but one is with regards to medications. Medications have been extraordinarily profitable to the pharmaceutical industry, and so that has driven intensive research and marketing, just general publicizing and promotion of a biocentric or biological substrate model, and then in the way things happen, something that's going on at a sort of industry or commercial level kind of trickles down into the science itself, and then before long you have a whole science of a particular area of human inquiry, such as mental health that has been infiltrated and influenced by the effects of the economics of the matter and the marketing and so forth. CBT in part, and again, there's probably many people, there are many people in the world who have received cognitive behavioral therapy who have really benefited from it, but it also has been way overinflated. And this comes to a large degree, this is CBT is something that is pretty presentable in terms of grants and so forth, and CBT research programs are already well established in many universities because it is possible to gather a lot of population data and present this as parts of grants, so it becomes established in universities, and then it becomes the focus of the research at the universities, and it's what gets pushed onto the students, including in clinical psych programs. So the that's I think that's what I wanted to say about CBT for now. Okay, as I said, there's cases in which CBT can be an effective treatment. Tends to be I remember the what I wanted to say about the problem with readily presentable grants in academic settings. This runs in I think the word I want is contradistinction to what I was saying earlier about the relational psychoanalytic approaches. So I can go here. Approaches that are where the data can be presented in terms of population and population studies are not looking at the nuances of a patient and a therapist, or a patient and an analyst. They're looking at large groups of people kind of taken as a whole, and the sort of homogenization that goes with that, and the kind of gross degree of generalization that goes with that. And that's problematic because anyone who has worked as a therapist or analyst or analytically informed therapist knows that a great deal of the action is in the atomistic moments between the patient, the therapist. And we know everybody who has had training in any kind of a mental health treatment profession has heard somewhere along the way that the factors that generalize, that always play a role in effective treatment, are relational factors, warmth, genuineness, these kinds of things. So those characteristics get translated into relational therapy approaches, and you can't really capture those well with population studies. So, but CBT has components that, again, are amenable to RCTs, randomized controlled trials. So it's what gets studied in academic settings, and then because academic settings accumulate all of this data and all these findings from CBT, it then gets promoted or even pushed on practitioners. So you have what works well in academic settings, and you have what works well in actual practice. They're not the same thing, but the one gets pushed on the other. I already mentioned, when medications come in, medications can be helpful to people where mental health is concerned. They're largely palliative. There's not really, I won't say never. There's cases in which, medications, say a depressed patient is taking antidepressant that is particularly potent for them in terms of improving their energy levels and motivational levels and so forth. And then they're able to kind of re-engage with life and actually go through a sort of a cure or healing process. So it can happen that medications are curative, but I think it's in the relative minority of the cases. Plus, you have all of these, side effects and so forth to deal with. And also, important fact: psychiatric medications have very significant placebo effect. And SSRIs kind of boil it down to therapeutic effect of SSRIs being something like 60 to 80% placebo, and maybe to a lesser degree with some other psychiatric medications. But I did tell you, I did just say, there are some cases where psychiatric medications can actually have a curative role. They can also have a role in relational approaches, wherein if a patient is requesting some immediate relief, they're kind of facing this long road of connecting with the therapist or analyst and forming a rapport and in a personal container in which they can bring their emotional experiences into the shared environment. And that will be the healing mechanism ultimately. But the patient's just in too much pain or anguish or suffering in the moment. They need some relief. In that case, a medication, if it provides that, can actually be a relational intervention in the sense that, okay, my therapist recognized how much pain I'm in and that I need something right away, and they validated that need. So, medications, CBT, can have help can be helpful, but I'm really just wanting to kind of put them in their place here and into some perspective relative to more relational and especially psychoanalytically informed relational approaches, which really should be in ascendancy at this point. Let's see, I think maybe I talked about some of these things. Yeah, just a little specific addition that thinking about, for instance, medications in relationship to a relational approach is useful. It does remind us that our mind and body are linked. My cute saying, I take my mind or body everywhere I go. It's true. Our psyches and our bodies seem to be pretty highly correlated. So it's worth thinking about how what one does with one pole of the continuum affects the other pole, but we need to think much more about how things start in the relational domain and our relationship with our environment, how that changes our affects or changes our body, and that piece has been underattended to. So one of the other pieces in this back and forth that I emphasized is that they're starting to find that even though direct effects, direct intervention of medications on mental health problems are inadequate as cures for mental health problems. Ironically, studies are starting to show that psychotherapies that affect biological change are perhaps have a greater impact or are more effective than psychotherapies that don't affect biological change. So in a way, this makes sense common sensibly. Again, going back to the previous slide, our minds and bodies are connected. And if I'm just changing one part of of the system, but something else, another important part of that system or continuum isn't changing, then something incomplete maybe is occurring. Somehow the continuum isn't being addressed as what it is, a continuum. And just sort of an ironic, and let me, before I go into the ironic thing, I'll say that why would psychotherapeutic approaches that change our body be more effective than psychotherapies that don't? But medications that change our body are not all that effective as cures. And there's different reasons, different ways to think about this. But just on the biological level, one of the reasons is as biological change agents, medications are probably far too simple and simplistic. Most psychotropic medications just target very limited neurotransmitters and receptor sites, whereas the biological changes that result as an outgrowth of relational experiences have vast and sweeping effects in our neuroendocrine system. And it may be that medications are just too simple as biological change agents. Down here I put, I don't know if my cursor shows up here, an exception that proves the point, chlorpromazine or clozaril. If any of you have worked on inpatient units or other environments where you have very severely psychotic patients, I worked on inpatient units pretty extensively. One of my observations is a lot of times improvement that gets, that's seen in a patient who comes on to an inpatient unit and is very psychotic and disorganized and acting out and so forth. When they first come out of the unit, they're there for a little while, they're resistant to taking their medications in the beginning. And after a while, they decide to adhere with the medications, and then the staff sees this improvement and says, oh, look, they did take their medications and now they're getting better. My observation is often what happens is the patient comes onto the inpatient unit. Now they're in a more contained setting. They have supports around them all the time. They start to stabilize a little bit, and they look around and they realize the patients who are getting off the unit are taking their medications. It's often a criteria for patients to get discharged from inpatient unit is to be medication adherent. So I think I'm not talking about clozaril yet. I'm talking about just antipsychotic medications in general that are pushed on patients on inpatient units, that I think a lot of what staff see on inpatient units that looks like patients getting better when they start taking their medications is actually patients starting to clear enough to see what will help them get off the unit. And one of those things is taking their medications. And then so they take their medication. And again, they may be getting some effect from the medication also, but much, there's a lopsided attribution of the effects of the medication on their improvement versus the containing environment they're in. This exception that proves the point is chlorpromazine, or it goes by the brand name of clozaril. This is, I haven't really kept up entirely with the pharmacotherapy developments and so forth, but back when I was working on inpatient units where antipsychotics were used quite a bit, this chlorpromazine was set apart from other antipsychotics because it affected multiple neurotransmitter sites versus other types of antipsychotics. And I would say that patients who I saw in the inpatient units who had very severe unremitting psychoses, even after they'd been on the unit for a while, they'd been taking other antipsychotics and so forth, when they were started on chlorpromazine, there was sort of a magical remission. And I think what happens there is probably a drug like this comes closer to approximating change that happens over time in a relational context. So again, because the relational interventions are ultimately affecting many more neuroendocrine events and receptors, many more neuroendocrine substances and receptors. And so chlorpromazine is kind of a better mimic of relational intervention than other antipsychotics. And of course, but with what the downside of this is a couple. One is the patient hasn't kind of had new relational experiences to internalize and affect healing, and chlorpromazine comes with some really serious, potentially very serious potential side effects. People can die from it. This is just quotes from a couple studies comparing psychotherapy and pharmacotherapy. I think as we get better at assessing relational approaches, we'll see that the effect sizes are even greater. I have some background noise on my end, somebody's song or something outside. Are people hearing that? Is it distracting?
No, we can't hear it.
Okay.
Yeah, can't hear.
Okay. If that changes, let me know and I'll close the door. And as I said, and I've actually been talking about it pretty extensively, preliminary evidence that neurobiological changes are associated with the progress and outcome of psychotherapy. So I've been talking about this. Just wanted to give you, a quote reference. Okay. So, I think one thing that's been and is being emphasized through attending and bringing in these different domains is this biological change piece that results from different degrees with different psychotherapeutic approaches, and there's reason to believe that relational approaches will affect that kind of change best, or the most. So the idea that's getting expressed in this slide is that we are doing something even more than we might realize with relational approaches. We know already that connecting with our patient, developing a rapport, and kind of providing a space and a container for our patient to work through his or her emotional conflicts is healing and curative. But now we can also think about these effects maybe have farther reaching effects. But my cute little saying, we shouldn't, these are good things to think about, but not when we are attuning with our patient, because that would be misattunement. And now I think we got the ordering of things right. Let's see. Yep. Now I'm talking about attunement. So this is a pivotal idea. Attunement's a pivotal idea in an object relations, developmental informed, relational psychotherapeutic approach. My model is very heavily based on the work of Daniel Stern, a psychoanalytic psychiatrist who did extensive research with mothers and infants. And I have my own way of kind of saying it, but as far as this piece of my model, I've kept a lot of adherence with his developmental model as my own approach has evolved. So I will spend a little bit of time talking about the stages of this. So attunement is a connection between one person and the other around affects, and it is, we're attuned if the other recognizes my affective experience and communicates that back to me in a way where I feel, yes, you've got it. That's exactly how I feel. You know, you're in working with patients, you know, you've had people say, yeah, that's it, right on the nose, you got it. That's it. Yes, you, those, you described it exactly. The patient's expressing attunement. You can think of it as a component of empathy. I think of empathy as a sort of combination of attunement and mentalization, which is sort of putting ourselves in another person's situation. But attunement is that very atomistic piece where we communicate back to the individual that this feeling you're having right now, I get that. I get that on a organismic, visceral level. So in infancy, how does what is where does this fit in early development? So in infancy, the baby and the mother, and I'm going to use baby and mother, but you can think of you know, mother as primary attachment figure, whoever that may be. You know, it's just easier for me to talk about baby and mother, and I think most of Stern's work actually was with the baby's maternal parent. But these processes can happen with any two people. So when the baby is born, he or she is essentially, just as far as he or she is concerned, an extension of the mother. They're not really two different beings. The mother is just sort of the universe that the baby is ensconced in. He or she has basically identification with the mother. And then as the baby matures and grows from the very beginning, this universe is that the baby is ensconced in, which is the mother, is communicating back to the baby his or her emotional experiences. So and you see, if you have children of your own, you had babies, or you know people that have, or you just generally have observed babies and their mother or parent interacting. You know, baby makes crying noise, and you know, mommy goes, oh, it's sad, or that hurts, or the baby smiles and giggles, and you know, mom, you know, lights up and smiles. This is affective attunement. The mother is, you know, viscerally responding to the baby's emotional experience and mirroring that to the baby. And you know, so a couple things simultaneously happen. It's part of the process of the baby differentiating from mother and self, because ironically, the fact that he or she is getting this sort of mirror means that there's a mirror. And at the same time, it communicates to the baby that this experience he or she is having, this emotional experience, is a shared experience with the universe. As far as the baby knows, mom, again, is, you know, the universe or survival. And it's very important to know one is aligned with the universe and survival, pretty fundamental needs. And I'll come back to that survival idea in a minute when we get into misattunement. So the fact that, you know, I am one with the universe, I am in good with the, you know, what it means to survive. This is going to put me at ease, or what Stern called soothing. So I have my affect, whether it's my sad or frustrated feeling, or angry feeling, or my happy and excited feeling. I know that I'm okay because I'm at one with the universe, and this has a containing effect. This is what we call affective containment. this very atomistic and complete connection with the major other, contains my affect. In other words, it reduces the anxiety that surrounds otherwise uncontained affects. So I won't get too far at this into this next what's called presence, absence, present sequence. This is a really important process that has to do with that explains how these attunement and containment experiences get internalized in the baby and young child over time through his or her successive interactions with the parent. And that's important enough for another talk, but just for the moment, this is what Stern is outlining through this sequence, and particularly when we get to this, presence, absence, present sequence, he's talking about how this identification, attunement, soothing, containment becomes internalized, or what in object relations they talk about is object representations or internalized objects, and that's what the baby and whom young child, whom adult carries around with him or her throughout life, that helps him or her to modulate affects over time, even when mother or father or other attachment figure is not there. He or she is able to modulate, provide for him or herself this kind of soothing and containment that makes it possible for him or her to go about his or her business even when experiencing strong affects. So we call it affect modulation. Okay, so again, the back and forth between the components. We have a 10 or 12 minutes, Mike, is that correct?
Yeah, we've got about 10, 15 minutes. 10 minutes.
Okay.
Yeah.
Okay. So I'd said a few times that relational approaches are perhaps superior and more effective at bringing about biological change than other approaches. Why would that be? That would be because the affective attunement sequence and process we just talked about is probably closely yoked with physiological regulation or co-regulation between parent and child. So even before, now there's I can't think of the theorist, probably somebody out there in the audience knows, who kind of popularized the idea of parent-infant co-regulation. I can't come up with the name, but the focus there, I think, really is affective co-regulation, which is very similar to the process I just talked about with Stern. I think whoever originated that term, is had somewhat different way of outlining that than Stern. But so when I'm saying physiological co-regulation, I think that's kind of a coined term because it's really affective co-regulation in the literature, but really, physiological co-regulation is present also from infancy and before in birth, even during gestation. Just the mother and the gestating fetus are co-regulating, the baby's nutrition and needs, and all the baby's physiological needs are being met through the mother, and the mother's body is picking up the baby's needs. So, and then that gets continued after birth as the mother responds to baby's cues and signals that he or she is hungry or thirsty or cold. Let's see if there's just looking at my own slide here to see if this slide adds anything I can't talk about in a more general way. Yeah, I'm going to skip this. I don't think it helps. Okay, so this is just to make it easy on myself. I just grabbed off of some, parenting page on the internet, an array of signs and signals babies use to communicate to a parent that he or she is experiencing some kind of physiological need. In this case, the focus is hunger. This is quoted directly off the page. So, turning the head side to side as if looking for food, opening and closing their mouth, like little birds waiting for the parent bird in the nest, turning their head toward the breast or chest or bottle, many more. Sucking, stirring, and nest sound. I'm not sure how to make the nest sound. If you're a parent or know recent parents, maybe you know what the nest sound is. Making sucking motions, smacking their lips, drooling, sucking on their fingers, hands, or clothing, punching their hands into little fists. They're getting a little frustrated and impatient. So the site that I pulled this off of was very convenient in mentioning that these physiological signs are associated, with hunger, but also frustration and impatience. So you can see where some of the physiological needs and communications are entwined with and almost intrinsic with affective communications. So some of my first experiences of things like, being frustrated or angry are associated with some physiological need not being met, or, smiles or happiness and contentment because some physiological need is being met or being physiologically comforted. So the attunement and containment processes associated with my affects are entwined with the regulation of the interpersonal attunement and containment of my affects are intertwined. Excuse me. Oh, it's getting bad. Physiological need met. The personal attunement and containment of the affects is intertwined with the interpersonal regulation of the physiological needs. So addressing the other interpersonally, affectively, i.e. relationally, has ramifications for what's going on physiologically for us. For any of us in relationship or interaction with another person, there are changes that take place physiologically associated with the ways that we attune with and contain each other. This is basically what I just said. Another coined word, I think this is my coined word, is yoked or yoking. The physiological co-regulation and affective attunement and containment become yoked with each other. I can't really address affects without also addressing the body or physiology. Misattunement is, and I can see I'm gonna have to kind of rush through the following slides here. So misattunement is kind of the opposite of attunement. We talked about, responding to others' expression of a feeling in such a way that that person feels like, yes, you got it. That's exactly what I mean. Misattunement is anything else. So if I, Claire, this is not even from a clinical example. This is just something that people may experience and often have experienced in a social situation. excuse me, they go through a very painful breakup with a partner. They're anguished, and their friend says, there's other fish in the sea, you'll meet somebody new. Basically, terribly misattuned, leaves the person feeling out in the cold and entirely misunderstood. As far as they're concerned, their life is over, and somebody's talking about the future, some other experience, has nothing to do with where that person's at emotionally. Like I say, that's just a very general kind of social situation type of misattunement. But it happens in therapy anytime when we're responding, really sorry about my coughing. Anytime we're responding to a patient's affects in some way other than being attuned with those affects. I'm not going to have really time to go into the clinical examples that I thought I would. Maybe you can read as I'm talking. This is really more a case of mother and her young child, and who was diagnosed with ADHD, and the mother's misattunement with that, the child's emotional needs, because his in the moment his acting out behaviors made her so anxious socially. That's sort of all she could focus on, and you know, she would find herself trying to correct her child's behaviors in those moments, or admonish him, or scold him, or explain to him why he can't act that way, and never got around to addressing what the child was feeling that was driving the acting out behavior and the attention shifts. Don't need to look at this slide. It just is something that everybody knows. Freud came up with the concept of defenses, further developed by Anna Freud. Others added different categorizations to the original defenses, the primitive defenses. Object relation defenses focus more on defending against affects, versus drive theory, where the defenses are more associated with the drives. So how would a child, so we talked about how the child internalizes attunement experiences and then carries that with him or her as an internalized representation of self and other that he or she can draw on to modulate his or her own affects. But why would a child internalize misattunement, or what does that mean? And I mentioned earlier the idea of survival. With a young child, remember, the attachment figure is everything, is the universe, is basically survival. And if it comes down to me in that dependent early childhood state, relinquishing my affects or relinquishing my source of survival, I'm going to relinquish my affects. So I internalize the relationship that I rely on or depend on to survive, and along with that, the idea that I just don't get to have access to certain affective experiences. And then I put defenses up around those affects. And those defenses are, and we have people know, a lot of the classical defenses, suppression, repression, reaction formation, projection, splitting, all of these things that people engage in to not have, not experience their affects. And then these defenses evolve or devolve into symptoms. So for example, with depression, the repression defense evolves into flatness of affect, loss of motivation and energy, and these kinds of things. So the progression is the misattunement, the defense, and then the symptoms, and then a constellation of symptoms becomes a disorder, like major depression or some other disorder. So why do I talk about attunement with defenses? Going back to the original title and thesis, we're essentially thinking of attunement as being with affects, how can we attune with defense, the absence of affects? The idea is that I'm still tuned with my patient where he is or her is at with regards to affects. So the affect may be hidden or submerged, but and replaced with a defense. But I, as the therapist, am aware of both the affect and the defense, and continue to so I'm going to come back to what I just said, again, the jumping a bit. So hold on to this idea of the attunement with affects, or attunement with defenses, kind of as a progression of attuning with affects. So this again is talking about the mother with the ADHD child. And in this case, her defenses around her affects are interfering with her attunement with her ADHD child at the affective level. Now, what I'm talking about here is not so much the therapist attuning with the patient's defenses. This is more directly attuning with the affects, where the patient, the mother of the child, is not attuned with the child's affects, and then we'll progress to attunement with defenses. But in the case of, and this also introduces where countertransference comes into this. So, you know, working with this mother, and I'm watching the mother and the child interacting. The child is very hyperactive in the office, all over the office, rushing this way and that. Mother's getting increasingly agitated and anxious. And my countertransferential urge is to explain to the mother how, you know, being so concerned with her own anxiety and her own, so concerned with her own sort of social desirability presentation is disconnecting her or misattuning her with her child. But this is countertransference, because this doesn't help this patient at all. She's very anxious. What good is it going to do me to give her a lecture and explain psychodynamics to her? So instead, I just attune with her anxiety, and I let her know I understand how uncomfortable it is for her to have her child acting in this way. And you know, in the meanwhile, in my mind also is an awareness that the child's acting this way because mom is not attuned with the child. But again, I know what the sort of the prime directive in the moment is for me to attune with the mother. And as I do this, she becomes less and less anxious, more and more relaxed, and more centered. And simultaneously, the child's hyperactive behavior decreases. And by the end of the session, he's sitting next to her on the couch with his head in her lap. So it was an effective intervention, largely owed to the fact I didn't let my countertransferential urge carry me away. Now, in this case, this one is more the idea of attunement with the defense per se. Like I said, I've worked with a lot of patients with compulsive behaviors. This is of those patients, this is much higher functioning patients than some of the patients I worked with on the in-person patient unit. This is a private practice patient who had a compulsive behavior pattern that was very distressing and ego dystonic to him. You know, he's highly motivated and committed to sort of changing this behavior. Now, you know, I'm working with him relationally and exploratorily, and in the course of our work together, over time, awareness of childhood developmental attachment problems have emerged, and traumas that emerged, including pretty severe misattunements with his father, with family members as a whole, but especially with his father. So my patient is in a big hurry to sort of eliminate these compulsions from his life, and the things that are happening in therapy are the right things that need to be happening. So over the course of time, he'll be able to access his relational emotional needs more directly, and will then, reach a point where he'll be able to kind of have greater freedom to relinquish the compulsions. But he's in a big hurry, so he's often, while he's in therapy with me, he's often looking outside of the therapy for other sort of quick fix types of things. And I say gimmicky, I don't want to convey that it's just like we talk about CBT. There's things that can be effective, very effective for some people. And I don't want to judge those things, but in this case, they're kind of quick fix or gimmicky things like EMDR, TMS, other things that, in, a few easy sessions, I'll rid myself of this deep-rooted compulsive behavior. So he's off, when he'll tell me about these things before he goes and seeks them out. And my countertransferential urge here is, again, I want to, have this urge to kind of educate him on the deeper dynamics of the problem, how, in his case, these things are not going to really impact in the way that he thinks they are. But again, this isn't attuned with where my patient at. He's feeling, very anguished and urgent. And I'm also aware here, and this is, another use of countertransference, it informs me about or confirms information I have about the transference. The patient's father was quite authoritarian. I don't think he was particularly abusive or anything, but he was sort of like, dogmatic. Here's a way to do things, stop doing that bad thing you're doing, just do this instead. So, part of what's driving my need to, or that urge to sort of, be corrective about my patient's thoughts with regards to seeking out these other, as I'm calling, quick fix or gimmicky therapies, is responding to the transference needs. So I pay attention to this, and I shift to attuning with his need to seek these out, his enthusiasm. So I'll talk with him about, that's interesting. What do you know about that therapy? Why don't you, what do you expect from it? And yeah, I can see why that would really be compelling, et cetera. And, and then he'll go try it out a little bit. And of course, it doesn't work, but it keeps him engaged, and it gives him a sense of, having some power and relationship to this problem he's trying to solve, and it preserves our relationship. And all the while, he and I, are building our rapport and continuing to arrive at these awarenesses about things he's run into in the course of his development relationship with his father and the rest of his family. And we've now also integrated a kind of, not in place of the relational exploratory therapy, but kind of included in it a more structured approach to changing compulsive behaviors that I bring with me from my work on the inpatient units. So he can, increases the likelihood of him sort of staying home as he tries out these new things. He can do that in the context of our therapy together. So that is what I call attunement with defenses, recognizing that it's very important to my patient to respond this way in terms of managing his feelings. So I'm honoring that, and we found a way to kind of do this thing together, which can also add to his repertoire of self-management. But the bigger role, I think, is that allows he and I to continue to connect and grow in our relationship together. Okay. I already talked about why it matters to think of the physiological outcomes. Just now getting to amygdala. The reason the amygdala is important in thinking about our physiology from this relational perspective. Amygdala's had a pretty long history in neuroscience and in neuroscientifically informed psychology and psychotherapy. It used to be thought of as kind of a fear-related structure that recognized or registered fear or fearful stimulus for the individual, but it's been found that amygdala is much more complicated structure than that. It has a lot of different roles, but in terms of what we used to think of as being sort of a fear register, it really seems to be more a register of salience. Something salient is happening in our environment, and it's salient, therefore it could have survival implications either for or against. So let's check this thing out further. So one of the things the amygdala does is it takes information, and here's a lot of different ways it takes information. These are all the afferent pathways communicating to it. The amygdala it receives information from a visual pathway, auditory pathway, olfactory or smell related pathway, and from the temporal lobes. But as you see, there's heavy emphasis on sensory perceptual information. You can see where interactions with another human being, where we're perceiving affects or mirroring or attunement with affects, facial expression, sound of voice, even smells, pheromones, and so forth that are part of human interaction are being registered in the amygdala. And if the attunement and connection, that containing soothing experiences there, other than the initial registering of that, the beginning of a relationship, that's going to become sort of non-salient. I'm not really going to have to pay that much attention if the other I'm with, the important other, is attuned with, and my experiences are contained. I don't have to pay too much attention to that. My amygdala doesn't do much with that because it's sort of a subtle matter. I'm in a safe situation. There's not a survival concern here. If the stimulus I'm receiving is salient, something isn't sort of familiar or sitting right, or as otherwise feels discrepant, that's going to get my amygdala is going to respond to that. An example of such a stimulus would be misattunement. The response I'm getting isn't reassuring enough or familiar enough. Maybe familiar is the best word for my amygdala to just kind of pass it off as inconsequential. Instead, it's going to send this information to other parts of my brain. For one, it's going to send it to the prefrontal cortex for further analysis of the situation. And from there, it may go in, the information may go in different directions, notably the hypothalamus. Here's just all of the innervations of the amygdala. Goes through all sorts of different parts of the brain, but especially of relevance here would be the prefrontal cortex, which is over here somewhere, and the hypothalamus. And the hypothalamus, the prefrontal cortex, is going to analyze this salient stimulus. Right now, we're talking about misattunement. Decide whether it's a matter of concern or not, and I'm going to react to that in some kind of way. The focus of this talk has been a reaction that represses my awareness of the event, because overriding the threat of the misattunement is the threat of disconnect from my attachment figure. So the amygdala plays a role then in sort of coordinating responses in other parts of the brain that essentially that allow me to stay connected with my attachment figure while repressing the affective experience. And essentially, this is how repression takes place. Are we there now, Mike?
Yeah, I think we're about there. Sure, it's very interesting. I could just go on though, but we probably should leave a bit of time for discussion. And we've got the next talk. We've got another talk also lined up. So look, yeah, it's up to you. But I think it would be nice to have a bit of discussion. How you
and I think, and I actually realized as I flipped through the next few slides that that's the stuff that was left really is for the next discussion. I think I included as sort of a preview. It kind of goes into this relates to stress. So I think we're at a good place to stop.
Yeah, okay, good. I've got a couple of questions. I mean, the one is about the medical psychology, because I'm not aware we have that as a category here in South Africa. We've got clinical psychology. But I found that quite interesting that you sort of practicing as you're doing psychology, but there's quite a medical focus. And I think when we spoke on a build up to the talk, you even spoke about how sometimes you might work with someone, and part of what you might do is even be reducing some of the medication, which I thought was such a exciting thing, because here, I mean, in terms of some of the psychiatric hospitals and centers, it's I think there's still a very big split between psychiatry and psychology. So, and sometimes you're working with people who are almost in a chemical straitjacket, their drives are just off. And it's actually quite sad, and one almost feels one wants to reduce medication so they can get a bit of a life back. But it feels that's the department of psychiatry and not our department. So I don't know if you could tell me a bit about being a medical psychologist, and also I'm quite interested in this. It's probably a bit of a broad and big question, the working with medication with people, and if you're reducing it.
It's a really good and apt two-part question, and the parts are kind of combined. I can draw on my own experience. You're talking about what you see with these patients that develop this kind of a flatness and the chemical straitjacket. As you said, it's very sad. It's also very, in my experience, is very sad, and it's very frustrating. Both of those elements acted as motivation for me to explore medical psychology, because I wanted to know more about, be able to impact more on a world that has, meaning the healthcare, and especially the mental health care world, that has become so medically or biologically centric. So in other words, those of us from the psychological realm, we know so much about pretty much every domain that impacts on human psychological health and well-being, except for the biological piece. The biopsychiatric community knows tons about the biological piece, but it's just so fractional in what causes, what's causing the person's suffering and problems, and as a pathway to healing. However, as I said before, it's so tied in to all of these kind of social, political, economic factors that this fractional piece that has a role, but really it's a very fractional role, in a much more dependent variable type of role than it gets played up as in psychiatry, that little fractional pieces has gained so much power in the mental health world, and that it overwhelms at times psychology and psychotherapy, and especially in hospital settings and in clinics and so forth, the voice of the masses, which is all the other our developmental, relational, situational factors, trauma, socioeconomic factors, all of these things that impact on our psyches and our mental health, the lion's share of it ends up getting squished and pushed to the side by this tiny fractional piece. So if psychologists and other more informed with regards to these other variables have a better handle on the biological piece, we're able to talk more effectively about the relationship with the variables, and we're able to introduce and argue for how these other approaches also can affect that fractional biological piece that is important, but it's not as important as it's been made out to be, and certainly it's not as determinist. It's not as much a determinant as it's been made out to be. So medical psychology is a sort of postdoctoral specialty to clinical psychology. A lot of the medical psychologists, if you think in terms of like on the left and the right, I'm kind of pretty far to the left with this relational centric thing. I have a lot of colleagues in medical psychology who take more of a combined treatment approach, something like CBT combined with medications. And there's a lot of medical psychologists in the United States. If they, depending on what state they live in, they can prescribe medications. In the United States, there's several states now where psychologists can prescribe medications. So the medical psychology kind of includes all of these, what they call RXP psychologists, which are psychologists who can prescribe medications. It includes people like me who are saying, well, we can affect these biological changes without even having to get into medications, because the biological factors are more of a dependent variable than they've been made out to be.
I mean, it makes such sense, though, doesn't it?
Yeah.
Especially when one's working with people who are on, heavy amounts of medication. Yeah, I mean, and it would make sense for this lecture that you had, that I suppose the psychiatrists should have a grounding in that. And yeah, but in South Africa, sadly, there's such a split. I mean, I'm not sure about in the States, between psychiatrists and the psychologists, and often in the hospitals, really, there's a big hierarchy. I mean, the psychiatrist is at the top, and the psychologist really doesn't interfere at all or suggest things. Or
you're as you're sharing, and I'm listening, of course. One of the comments came up from Sam Lutz, who said yes with exclamation points and thumbs up. Kind of, I think a lot of people are excited about this, in both in terms of how we're provoked by the biopsychiatric community, and also about the potential for coming at this in a different way. So, your questions and comments are, highlighting, Mike, are highlighting some parts of this that really are dear to us working in this field. I realized one of the parts of your question I didn't fully answer was about the kind of on the material level of relational intervention versus medications and going off medications. And that, as I get into, the next talk, when I get further into the stress physiology and so forth, we can look at how these relational approaches not only are registered in the nervous system in the moment, in a particular way having to do with safety and security, but over time can reverse processes in the body governed by what's called our hypothalamic pituitary HPA axis, that has lots of offshoots from it throughout the body, can result in changes in serotonin in the brain and so forth, and things that you would get connected to medication, serotonin selective reuptake inhibitors. Those things can be changed in other ways. So that's why, and I have had, and I know in a a preliminary discussion, I shared, I've had many patients in my private practice over the years who were on medications when they started therapy, who have since gone off them, where they reduced their doses. Not every single one. Some people, for one reason or another, they find it beneficial to stay on a medication. It's up to them. It's relational centric practice. I'm not going to, tell my patient what they have to feel good with, but many patients are able to let go of the medications as they're able to modulate their affects better.
Yeah. We've sort of come to the end, and I've sort of got so many questions and thinking about the link with neuropsychoanalysis, but thank you very much, Jeff, and I look forward to continuing the discussion, and thank you everyone for attending.